today we will discuss our topic, that is acute kidney injury. As we all know that the function of our kidney is to filter the waste product from our blood. If our kidney is not functioning properly, then the waste products like urea, creatinine and nitrogen, they all will get accumulated and they will lead to chemical makeup unbalance, right? So here we go, let's start. So the content today we will discuss will be our introduction part, will be staging, will be symptoms, we will call it as a clinical manifestation also, and etiology, pathophysiology, diagnostic parameters and treatment. So let's start with the introduction part. Okay, as we all know, as I have discussed earlier also, that in acute kidney failure, our kidney is unable to filter the waste product from our blood, and due to which there will be the elevated level of the waste product like urea, nitrogen, creatinine. So there will be a imbalance of the blood chemical makeup. Okay, so there are some few terms which is used during the acute kidney injury. Number one term is anuria. During anuria stage, our kidney stop producing urine. And if we discuss about the oligouria, in oligouria, our urine output is more than 400 ml per day or less than 20 ml per hour. And it is the first sign of renal impairment. It is the earliest sign of renal disease. So if we discuss about the polyuria, in polyuria stage, there will be excessive urine volume. It will be equivalent to more than 2.5 liter per day. And if we discuss about the azotemia, there will be elevated level of urea and other nitrogenous compounds in the blood. Okay, so metabolic acidosis, in the stage of metabolic acidosis, there will be a buildup of acid in the body due to the reduced ability of the kidney to filter the waste substance. So while considering all factors like anuria, oligouria, polyuria, and metabolic acidosis, azotemia, right? So acute renal failure is a condition in which our renal function is decreased and it will result in the accumulation of the nitrogenous compounds. Okay, so here I have mentioned serum creatinine and blood urea nitrogen because it is the most important renal health indicator. Okay, as we all know, first we will discuss about the serum creatinine. As we all know that serum creatinine production is dependent upon the muscle mass. And in journal, the normal value of the creatinine is 0.7 to 1.3 mg per dl in men and 0.6 to 1.1 mg per dl in women. There are multiple reasons when the serum creatinine level can elevate it, right? It can be due to urinary tract obstruction, due to the calculi, or it can be due to sepsis. It can be due to dehydration. It is the most common cause of the kidney disease, right? So there are some few factors which can lead to the higher level of the serum creatinine, like blocked urinary tract, dehydration, kidney damage, or reduced blood flow to the kidney, right? And if we discuss about the blood urea nitrogen, it is also important indicator of the renal health, right? So its normal value is 1.8 to 7.1 mmol per liter and 6 to 20 mg per dl. If we discuss in journal how our kidney function, how kidney used to filter the waste substance, right? Okay, so liver, it produces the ammonia, and then ammonia, which contains the nitrogen, it breaks down the protein which is utilized by our body cells. If I say in a journal definition, in a journal manner, it means that the liver will convert the more toxic substances into the less toxic substances, right? After that, the nitrogen will combine with other elements like carbon, hydrogen and oxygen to form the urea. And then urea will transport from liver to kidney through our bloodstreams. And then the kidney will filter the waste products from your blood through urine. Got it? But in case of the acute kidney injury, this process will result in the accumulation of the urea and other nitrogenous substances. Okay, the main cause of increase BUN can be increase or it can be decrease also, right? The main cause of increased BUN is if we take high protein diet like lentils, right? Any dairy products like paneer, got it? And if there is a decrease in GFR, okay, so the BUN level can be increased. And in case of decrease in BUN, there will be a severe liver disease. As I have discussed earlier also, that in liver disease, in journal, liver release the ammonia, and ammonia contains the nitrogen compound, and then the nitrogen will combine to form the urea, and then urea will transport from liver to kidney, and then the kidney will filter the urea from blood through urine. But in the liver disease, this step will not occur. It will lead to the accumulation of the urea, right? And in case of syndrome of inappropriate antidiuretic hormone, as we all know that antidiuretic hormone is released at the time when our blood pressure is reduced, right? So it will tell the kidney to retain more water. If there is a inappropriate antidiuretic hormone, if there is a high level of this hormone, it will tell the kidney, it will tell the body to retain more water. Okay, so introduction part is completed, right? Now we will come to the staging part. First stage is normal kidney disease, right? If there is a normal kidney functioning, then the GFR will be 90 to 120 ml per minute, okay? And in case of second stage, that is incompensated stage, the GFR will be 60 to 89 ml per minute, okay? Normal and incompensated. Third stage is exothermic stage. In exothermic stage, the GFR will be 30 to 59 ml per minute, right? First is normal, second is incompensated, third is exothermic, fourth is uremic. In uremic, the GFR will be 15 to 29 ml per minute. And when there is a last stage of kidney disease, the person will need the dialysis, the GFR will be less than 15 ml per minute, okay? So how we calculate the GFR? There is one formula, that is 140 minus age into lean body weight upon serum creatinine into 72, and in case of female, multiply with 0.85, okay? So now we will come to the symptom part, that is the clinical manifestation also. So there will be a decreased urine output, there will be fluid retention, there will be hypertension, and there will be hyperkalemia, there will be nausea, vomiting, there will be ascites. Ascites is when there is accumulation of the fluid in the peritoneal cavity, right? There will be a peripheral as well as pulmonary edema, whether pitting. Pulmonary edema can be pitting or non-pitting edema, right? And there will be loss of appetite and encephalopathy. As we all know that in encephalopathy, the liver will unable to filter the toxins from the blood, right? So it can lead to loss of consciousness plus coma, okay? So there are multiple causes of ARF, but the main causes are post, intra and pre-renal causes, okay? So generally the damage can be occur due to the reduced kidney blood flow, that is a pre-renal cause, okay? And if there is any inflammatory process or any damage to the kidney due to the harmful substance like aminoglycoside antibiotics, as we all know, like gentamicin, tobramycin, streptomycin, right? These all are the aminoglycosides antibiotics. They can freely cross across the glomerulus, right? So it can also cause damage to the paroxysmal tubular cells. And there is any anti-inflammatory process in the kidney. It can also lead to the kidney disease, and the most common cause is dehydration, as I have told you in the introduction part also. Okay, so as I have told you, there are pre-renal, intrarenal, and another one is post-renal, right? Pre-renal cause occur when there is a reduced renal blood flow. We will discuss the causes later on. I have one table prepared, okay? So intrarenal causes when there is an intrinsic injury to the kidney due to any harmful substances like I have discussed, like aminoglycosides antibiotics, right? Or any inflammatory process. And in post-renal, there will be obstruction in the urine flow, okay? If we talk that majority of the people is suffering from the pre-renal cause when there is a hypoperfusion, reduced renal blood flow, and 35 to 40% are suffering from intrarenal, and less than 5% people are suffering from the pre-renal kidney disease. Okay, so here are the causes. And if we talk about the pre-renal cause, Sepsis is number one cause, that is there is the infection in our blood. Dehydration, as I have told you earlier, and in cardiac failure, as we all know that during the kidney disease, our heart will not pump efficiently as it should be. So, the main vein which is connected to the kidney will build up the more pressure, so there will be congestion of blood in kidney too. So, it can lead to the kidney disease. And another one is vascular occlusion. It can be partial and it can be complete vascular occlusion, right? There will be a diminished blood supply. So, if we talk about the intrarenal cause, it can be due to the glomerulonephritis, right? Diabetes mellitus, nephrotoxic drugs, as I have told you earlier, like aminoglycosides, antibiotics, right? And infection, any inflammatory disease, right? If we talk about post-renal cause, it can be due to the renal calculi, cervical cancer, bladder abnormality, or it can be a bladder cancer also, right? Or it can be a renal stones also, right? Okay, so here is the pathophysiology, prerenal, intrarenal and postrenal. As I have told you, prerenal can be due to the reduced renal blood flow, right? There can be azotemia. Azotemia, as we have already discussed, that the urea and other nitrogenous compounds will get accumulated, right? So, if the renal blood flow is interrupted, then there will be a damage to the kidney, right? And our GFR will get decreased, there will be electrolyte imbalance, and there will be a buildup of acids in the body, which is called metabolic acidosis. We have discussed the term in the intro part, if you remember, right? Let's move forward. Okay, if we talk about the intrarenal cause, as I have told you, when there is a nephrotoxic substance that can cause the injury, any inflammatory process, or any ischemia, reduce the blood supply of the excision, right? So, intrarenal cause is associated with ischemia and nephrotoxic substances. There will be mostly in intrarenal, if we talk about intrarenal cause, right, there will be mostly the acute tubular necrosis, right? It accounts to oliguria. 90% cases it accounts for oliguria. As we have discussed earlier, oliguria is a stage when the urine output is 400 ml per hour, right, or less than 20 ml per hour. Retake. Oliguria is a stage when the urine output is more than 400 ml per day or less than 20 ml per hour. Okay? Okay. So, there will be a destruction of the epithelial cells due to the hypoperfusion, that is the reduced renal blood flow, or when there is a direct damage to the nephrotoxins, right? Okay, if we talk about the post-renal cause, there will be obstruction in the urinary tract, right? It can be due to, as we have discussed, any calculi, any stones, any bladder abnormality, any cervical cancer, right? So, move to the next slide. If we talk about the diagnostic criteria, right? In urine analysis, we generally see 6 things. Number 1 is red blood cells. Number 2 is epithelial cells. Number 3, cast. 4, crystals. 5th is albumin and 6th is sugar, right? So, whenever a person is having a kidney disease, there will be a symptom that is called hematuria. Hematuria, as we all know, that there will be a blood in urine, right? It can be due to the glomerulonephritis, when there is an inflammation in the glomerulus, right? Or due to the infection, it can lead to the hematuria. Okay, cast, crystal, epithelial cells, pus cells, they all are present because of the infection, right? Okay, so albumin, as we all know, when kidney is damaged, so protein will leak out of the kidney into the urine. So there will be a stage which is called proteinuria or albuminuria. So normal value of the albumin is 30 mg per gram. Okay. So let's move forward. We will take the specimen, urine specimen for culture if there is any infection. Okay. And then there will be a blood test of urea, electrolyte, there will be electrolyte imbalance, okay, CBC, LFT, RFT. We have discussed that how our LFT will get abnormal because liver produces the ammonia, the same cycle will get repeated, right? So ammonia will contains the nitrogen, and nitrogen will break down the protein which is utilized by our body cells, right? And then the nitrogen will combine to some carbon, hydrogen, oxygen to form urea, right? And then the urea will move out of the kidney, okay? The urea will move out of the kidney through urine, okay? So in CBC, the main factor is WBC count will be abnormal. Why? Because of the infection, right? hemoglobin will be low. In kidney patient, the hemoglobin is not all the time we can say that the hemoglobin is low, but in extreme case, in extreme stage, the hemoglobin is low. Why? Because kidney release the hormone which is called erythropoietin. Okay, erythropoietin. Erythropoietin gives signals to the bone marrow to release RBC, that is the red blood cells. If the kidney is damaged, erythropoietin will not be released. Okay, so that's why our hemoglobin level is low in the patient having the kidney disease. Okay, so we can check out the ultrasound, CT scan, renal ultrasonography. Okay, you can check the urine volume as we have discussed in the intro part, the term anuria, oliguria. Anuria is a stage when the kidney stop producing urine. Okay, and oliguria is when the urine output is more than 400 ml per day and less than 20 ml per hour. And renal biopsy and renal angiography. Okay, so the diagnostic part is completed. Okay, so here we go, the treatment. In the kidney disease, there are a lot of complications, like there will be high blood pressure, there will be anemia, okay, there will be a calcium level will be low. Okay, so we will discuss one by one. Okay, the high blood pressure medication is we used as ACE inhibitors or angiotensin II receptor blockers. ACE inhibitors drugs are captopril, enalapril, right? And angiotensin II receptor blockers drugs are valsartan, losartan. Medication to relieve swelling, that is used as diuretics. It can be potassium sparing diuretics, it can be thiazide diuretics, okay, it can be loop diuretics. And medication to treat anemia, as we discussed earlier, that why the hemoglobin level is low, we give erythropoietin injections, and we can add the iron tablet also. Medication to protect your bones. Okay, so we haven't discussed that why the calcium level is reduced. In the kidney disease, the calcium level is reduced and the phosphate level is elevated. Why? Because the parathyroid gland releases the parathyroid hormone. Okay, the parathyroid hormone secretion will be increased. It exerts the negative feedback, calcium basically exerts the negative feedback which will lead to accumulation of the phosphate and increase the bone resorption and increase the calcification. So that's why the phosphate level is high and the calcium level is low. So we give the vitamin D supplements or calcium. Okay. And at the end stage of the renal disease, we give last option, that is dialysis, or it can be a kidney transplant also. Okay, dialysis, as we all know, it is used to remove the waste product and the extra fluid from your blood when the kidney can no longer filter the waste products. Okay, in hemodialysis, it can be two types, hemodialysis, peritoneal dialysis. In hemodialysis, we use a machine, that is hemodialyzer, which filters the waste products from the blood. And in peritoneal dialysis, a thin tube is inserted in the abdomen, which fills the abdominal cavity with the dialyzing solution, which absorbs the excessive fluid and the waste products. Okay, after a time, the dialysis solution will drain from your body, which carry the waste products. So that's it. We have discussed the intro part, symptoms, staging, diagnosis, treatment and pathophysiology. Thank you so much.